Hey there, future healthcare heroes. Welcome back to the Deep Dive, where we unpack complex medical knowledge and really make it click. Today, we're diving deep into a fascinating and incredibly important trio of organs: the liver, pancreas, and gallbladder. They might seem like separate players, but their digestive functions are profoundly intertwined,
Mm,
and a problem in one can quickly become a crisis for the others.
absolutely. This deep dive is all about giving you the critical insights you'll need as nursing students, building on, well, the foundational knowledge from your medical surgical nursing texts. We'll explore how issues in these vital organs, from inflammation to obstruction, can impact everything from nutrient absorption to a patient's entire system. Our mission today is to equip you with the essential pathophysiology, the clinical manifestations you'll spot, the diagnostic clues, and most importantly, the nursing management strategies that define excellent care.
Think of this as your shortcut to connecting those textbook concepts to real-world patient scenarios. We're going to give you those aha moments, demystify the jargon, and show you exactly where your nursing assessment and interventions make all the difference. Get ready to distill some surprising facts and crucial nursing insights that will elevate your practice. I, the liver. Hepatitis, the silent attacker. Let's start with the liver, that incredible powerhouse organ. Our focus today is hepatitis. At its core, what are we talking about when we say hepatitis, and what are the primary culprits behind it?
Simply put, hepatitis is inflammation of the liver. While there are various causes, viral infection is by far the most common. But it's crucial for nurses to remember that other factors can trigger this inflammation, including substances like alcohol, certain medications and chemicals, along with autoimmune diseases and metabolic issues.
Okay. And when we zero in on viral hepatitis, we're often focusing on types A, B, and C, though D and E are also important. Today, let's really dive into the big three, A, B, and C, because understanding their unique transmission routes is so key to preventing them, right?
Excellent point. Knowing how they spread dictates how we intervene. It's fundamental.
All right, let's break them down then. Hepatitis A, or HAV. This is generally a self-limiting infection, often presenting as a mild flu-like illness, sometimes with jaundice. It's an RNA virus, primarily transmitted through the fecal-oral route. Think contaminated food, milk, or water. Poor hygiene, crowded living situations, improper food handling, major risk factors.
Mhm.
And here's a critical point for prevention.
Hmm.
The greatest risk of transmission actually occurs before symptoms even appear. The virus is shedding in feces 1 to 2 weeks prior to onset. That's a game changer for understanding how quickly it can spread.
It really is. Makes contact tracing and hygiene education even more vital.
Lifelong immunity follows either infection or vaccination. So your best defenses: thorough hand washing, and thankfully we have a very effective vaccine.
Essential tools.
Now, hepatitis B, or HBV, this is a DNA virus, a bloodborne pathogen, and it can be acute or chronic. Transmission occurs perinatally from mother to infant, percutaneously through things like IV drug use or needle stick injuries, or via mucosal exposure to blood or body fluids like semen or vaginal secretions. Sexual transmission is quite common.
Yes, and certain populations are at higher risk.
Exactly. You'll find increased risk in healthcare personnel, hemodialysis patients, and anyone living with chronically infected individuals. A key takeaway for patient education is that carriers can remain infectious for life.
That's a really crucial point for long-term management and prevention.
And chronic HBV carries a significant risk of liver cancer and cirrhosis. The good news: we have a highly effective vaccine, typically given in a 3-dose series starting at birth, which is absolutely crucial for prevention.
Prevention is definitely the best strategy with HPV.
Then there's hepatitis C, or HCV, another bloodborne RNA virus, primarily transmitted percutaneously, most commonly through shared needles among IV drug users. High-risk sexual behavior also increases risk, especially in men who have sex with men, MSM, particularly those living with HIV, due to certain cofactors.
Mm-hmm.
What's particularly challenging about acute HCV is that it can be hard to detect, with many people unaware of their infection because symptoms are often mild. A significant percentage, maybe 75 to 85%, will go on to develop chronic HCV. This is a common reason for liver transplantation in the U.S.
It's a silent epidemic in many ways.
Exactly. While there's currently no vaccine, here's the truly groundbreaking news. Direct-acting antiviral, or DAA, medications have revolutionized treatment, achieving a cure in over 95% of cases. Yeah, that's a massive shift in prognosis, isn't it?
It truly is a remarkable advancement in medicine.
So prevention focuses heavily on screening, rigorous infection control, and modifying high-risk behaviors.
Absolutely. And regardless of the specific cause, the core pathophysiology involves the liver's hepatocytes becoming targets, either directly damaged or attacked by the immune response. During an acute infection, there can be massive destruction of these liver cells, which then directly impacts critical liver functions like, bile production, coagulation, glucose metabolism,
Yeah,
detoxification.
those vital jobs the liver does.
Exactly. If it resolves without complications, the liver has an impressive ability to regenerate. However, chronic hepatitis leads to persistent destruction, scar tissue formation, fibrosis, and ultimately the irreversible damage of cirrhosis.
That's a clear picture of the underlying damage. But on the floor, what are the earliest or most critical clues we might catch? Are there subtle signs nurses should be acutely aware of that might precede the more overt symptoms?
That's a vital question for assessment. Many with acute hepatitis are actually asymptomatic, which makes early detection a challenge. Others will experience flu-like symptoms, anorexia, lethargy, nausea, vomiting, a general feeling of malaise, muscle and joint pain, and right upper quadrant, or RUQ, tenderness.
Okay, pretty nonspecific sometimes.
Yes, initially. A classic, unmistakable sign, though, is jaundice, the yellowish discoloration of tissues, often seen first in the sclera of the eyes. This happens when the liver can't properly metabolize or excrete bilirubin. You'll also notice dark urine due to bilirubin excretion, and if bilirubin can't reach the intestines at all, clay-colored stools.
Right, those are key indicators of bile flow issues.
Definitely. Pruritus, or intense itching, can occur from bile salts accumulating under the skin. As jaundice fades, the convalescent phase brings continued malaise and fatigue. It can linger. For chronic hepatitis, the signs can be even more subtle. Persistently elevated liver enzymes like ALT and AST.
The LFTs.
Right, though paradoxically, they can sometimes even be normal if too many liver cells have already been destroyed. Patients might eventually develop ascites, that's fluid in the abdomen, asterixis, the liver flap tremor, bleeding problems, fatigue, and of course jaundice.
So if we suspect hepatitis, how do we pinpoint the specific type and truly assess the extent of the damage? What tests are we looking at?
The only definitive way to identify the specific type is through specific antigen and antibody blood tests. For example, a positive HAV IgM indicates acute hepatitis A infection, while HBsAg indicates active HBV infectivity. For HCV, HCV RNA testing confirms an active infection. It detects the virus itself.
Okay, so specific markers for each virus.
Exactly. Beyond these specific viral tests, you'll look for significant abnormalities in liver function tests: elevated ALT, AST, alkaline phosphatase, and bilirubin. Prothrombin time, PT, can also be prolonged due to decreased prothrombin production, signaling impaired liver function.
That makes sense. The liver makes clotting factors.
Precisely. While a liver biopsy is sometimes used if diagnosis is uncertain or to determine the degree of fibrosis in chronic cases, non-invasive tests like ultrasound elastography or FibroScan are increasingly common for assessing liver stiffness and fibrosis. Less invasive, which is good.
Okay, understanding all that, the critical question for our future nurses becomes, what do we do? What are the immediate management priorities, especially for acute viral hepatitis?
Right. With acute viral hepatitis, since there's no specific cure, our treatment is primarily supportive. The emphasis is on adequate nutrition and rest to allow the liver to regenerate. As nurses, we teach patients to avoid alcohol and other hepatotoxic drugs. That's huge.
Crucial advice.
If anorexia is present, small, frequent meals are often better tolerated, and ensuring adequate fluid intake, typically 2,500 to 3,000 millimoles per day, is vital to prevent dehydration. For chronic HBV, drug therapies like nucleoside and nucleotide analogs aim to suppress viral replication long-term. Not a cure, but suppression. And for chronic HCV, as we discussed, those DAAs offer a cure.
Which is amazing.
It really is. From a nursing perspective, health promotion is huge, emphasizing meticulous hand washing, proper hygiene, and vaccination for HAV and HBV. For patients with active infection, rigorous infection control precautions are vital. Standard precautions, sometimes contact depending on the situation, especially with HAV. We monitor for symptom changes, ensure comfort, manage things like pruritus, and provide thorough patient education on preventing transmission and recognizing complications. And critically, alcohol cessation is paramount in all forms of liver disease as it just exacerbates the damage.
The end stage of liver disease.
Okay, so building on that discussion of chronic liver damage, cirrhosis represents the irreversible end stage of liver disease. It's characterized by widespread destruction of liver cells, which are then replaced by fibrotic scar tissue and disorganized regenerative nodules. This isn't an overnight process. It develops over decades of chronic liver damage.
So what actually drives this extensive scarring and ultimately organ failure? What are the main culprits you see?
Well, in the U.S., the most common causes are chronic HCV infection, non-alcoholic steatohepatitis, or NASH, that's fat buildup causing inflammation, and of course, alcohol-induced liver disease. Chronic inflammation from viral hepatitis, coupled with factors like malnutrition often seen in alcohol-induced disease, really accelerates this progression. This disorganized regeneration profoundly distorts the liver's normal structure, impeding blood flow and leading to severely impaired liver function. Imagine a healthy, organized filter becoming a chaotic, scarred maze.
That's a powerful image. And as that chaos takes hold, it brings with it some truly serious complications that you will definitely encounter in practice. Let's dive into those major clinical manifestations that every nurse needs to anticipate.
Okay. The structural changes in cirrhosis lead to increased pressure within the liver's circulatory system, a condition we call portal hypertension. Think of it like a major highway getting blocked. Blood is forced to find alternate routes, creating collateral channels, essentially detours, in fragile areas like the esophagus, stomach, abdominal wall, and rectum.
So the blood backs up and finds weaker paths.
Exactly. This leads to esophageal and gastric varices. These are tortuous, enlarged veins that are incredibly fragile and bleed easily. A ruptured varus is a life-threatening medical emergency, often presenting with hemamesis, vomiting blood, or melena, those black tarry stools.
Okay, that's a big one to watch for.
Definitely. Another common manifestation is ascites, the accumulation of serious fluid in the peritoneal cavity. This occurs due to several mechanisms working together. That increased portal pressure, pushing protein-rich fluid out, low albumin levels, hypoalbuminemia, because the damaged liver can't synthesize it.
Right, albumin keeps fluid in the vessels.
Precisely. And hyperaldosteronism leading to sodium and water retention. It's a perfect storm for fluid accumulation. You'll see abdominal distension, weight gain, maybe an averted umbilicus. Critically, these patients are also at high risk for spontaneous bacterial peritonitis, SBP, a dangerous infection of the acidic fluid that can be rapidly fatal if not caught early.
You've painted a vivid picture of the physical toll of cirrhosis. But one aspect I know concerns many families is the neurological changes, sometimes quite dramatic. Can you unpack what's happening in the brain with hepatic encephalopathy and maybe explain the mechanism behind that characteristic liver flap tremor?
Yes, that's hepatic encephalopathy. It's a neuropsychiatric condition resulting from the liver's inability to detoxify the blood, especially removing ammonia. Ammonia, primarily from bacterial breakdown of amino acids in the gut, builds up and crosses the blood-brain barrier, essentially acting as a neurotoxin.
So it poisons the brain, basically.
In essence, yes. Factors like GI bleeding or even just constipation can precipitate or worsen an episode because they increase ammonia production or absorption. Manifestations range widely, from subtle sleep disturbances and impaired concentration to deep coma. The characteristic sign you'll often observe is asterixis, or liver flap, an involuntary, jerky flapping tremor most often seen in the hands when the patient extends them, like a bird flapping its wings. Patients may also have a musty, sweet odor to their breath called fetor hepaticus and show marked changes in writing or fine motor skills. Early signs can be subtle changes in personality or cognition.
Wow. This sounds incredibly complex, requiring really meticulous nursing care. As nurses, how do we strategically manage these critical complications, often simultaneously?
Our care goals for cirrhosis focus squarely on slowing progression and managing these life-threatening complications. It's often about symptom management and preventing crises. For ascites, sodium restriction, often down to 2 grams per day, is paramount, along with diuretic therapy, usually a combination of spironolactone, an aldosterone antagonist, and a loop diuretic like furosemide.
The potassium-sparing and loop diuretic combo.
Exactly. You have to closely monitor fluid and electrolytes, especially for hyponatremia and hypokalemia, as these can shift rapidly with diuretics and fluid shifts. If medical management isn't enough, a paracentesis may be performed to manually remove fluid. Your nursing role pre-procedure includes ensuring the patient voids to avoid bladder injury, getting baseline vitals and abdominal girth measurements, and positioning them comfortably, usually in a high Fowler's position.
Okay. And post-procedure?
Post-procedure, rigorously monitor for hypovolemia blood pressure drops, tachycardia, check the dressing for bleeding or fluid leakage, and reweigh the patient to assess fluid removed. Severe ascites can also cause dyspnea due to pressure on the diaphragm, so positioning in semi-Fowler's or Fowler's is crucial for respiratory efficiency. And don't forget, meticulous skin care due to edema and potential skin breakdown. That stretched skin is fragile.
Good point. What are the varices?
For esophageal and gastric varices, the main goal is preventing bleeding. This means educating patients to avoid alcohol, aspirin, and NSAIDs, anything that can irritate the GI tract or impair clotting. Patients at risk may receive non-selective beta blockers like propranolol to reduce portal pressure. It lowers the pressure in those fragile veins. If a variceal bleed does occur, it's an absolute emergency. Stabilize the patient, manage the airway immediately. Aspiration is a huge risk. Start by IV fluids and blood products.
All hands on deck.
Absolutely. Administer drugs like octreotide or vasopressin to constrict splanchnic arteries and reduce bleeding into the portal system. Endoscopic therapies like band ligation or sclerotherapy are used to stop active bleeding directly. If bleeding is uncontrolled and severe, balloon tamponade might be used, inserting a tube with balloons to put pressure on the bleeding sites. But this is a high-risk procedure, a critical safety point. Always keep scissors at the bedside to cut the tube and deflate the balloons quickly if the gastric balloon breaks or migrates, which could obstruct the airway.
Wow, that's a crucial safety measure.
Okay.
And for hepatic encephalopathy?
For hepatic encephalopathy, our primary focus is reducing ammonia formation and absorption. Lactulose is a key medication. It traps ammonia in the gut by acidifying the colon, and its osmotic laxative effect helps expel it in the stool. You actually titrate the dose to achieve 2 to 3 soft stools per day.
So the goal is frequent bowel movements.
Yes, that's how the ammonia gets out. Antibiotics like rifaximin may also be used to reduce ammonia-producing gut bacteria. Nurses must ensure these frequent bowel movements occur. Crucially, maintain a safe environment due to the patient's altered mental status. Fall precautions are essential. Perform neurological assessments at least every 2 hours, looking for changes in orientation, level of consciousness, and asterixis. Avoid sedatives, as they can worsen encephalopathy. And remember to also address the patient's body image, as jaundice, spider angiomas, gynecomastia. These can be very distressing.
That's comprehensive care. And for patients living with cirrhosis long-term, what's our role in patient education to empower them in managing this chronic, complex illness?
It's absolutely vital. We need to teach patients and caregivers that cirrhosis is a chronic illness requiring continuous vigilant care. It doesn't go away. We educate them on avoiding hepatotoxic drugs, checking OTC meds too, and repeatedly emphasize abstinence from alcohol to prevent any further progression. It's non-negotiable. Teach them the signs of complications like increasing abdominal girth, signaling worsening ascites, bloody or tarry stools indicating a potential bleed, or subtle changes in mental status heralding encephalopathy and stress when to seek immediate medical attention. Empowering them with this knowledge truly makes a difference in their prognosis and quality of life. 3. The pancreas. Acute pancreatitis, a digestive crisis.
We've seen how the liver can quietly battle chronic inflammation, sometimes leading to irreversible damage. Now let's shift to another crucial digestive player, the pancreas. When this organ gets inflamed, it creates a very different kind of crisis, often immediate and agonizing. What happens when its own powerful enzymes turn against it?
That's a great way to put it. Acute pancreatitis is an acute inflammation where pancreatic enzymes, which are normally activated only after they reach the intestine to digest food, become prematurely activated within the pancreas itself. This leads to autodigestion. The pancreas literally starts digesting itself, causing severe pain and inflammation that can range from mild edema to devastating hemorrhagic necrosis.
Ouch. What typically triggers this premature activation?
In the U.S., the most common cause is gallbladder disease, specifically gallstones getting stuck near the pancreatic duct. This is more frequent in women. The second most common cause is chronic alcohol use, often seen more in men. Alcohol is thought to significantly increase pancreatic enzyme production and potentially cause spasm of the sphincter of Oddi.
Okay, gallstones and alcohol. Got it. That sounds incredibly painful. What are the hallmark signs and symptoms that scream acute pancreatitis to a nurse?
The cardinal manifestation, without a doubt, is severe abdominal pain. It's usually located in the left upper quadrant or mid-epigastrium, often radiating directly to the back because the pancreas is retroperitoneal, sitting behind the stomach.
So back pain is a key feature.
Often, yes. Patients describe it as deep, piercing, continuous, and steady. And a critical assessment clue is that it's typically worsened by eating. Food intake stimulates enzyme release. This pain is often not relieved by vomiting, like some other abdominal conditions. Other signs you'll observe include nausea, vomiting, a low-grade fever, leukocytosis, high white blood cell count, hypotension, and tachycardia, signs of inflammation and potential fluid shifts.
What would you find on abdominal assessment?
On assessment, you might find abdominal tenderness, muscle guarding, and decreased or absent bowel sounds due to paralytic ileus. The inflammation can shut down bowel motility. In severe cases, watch for gray Turner spots, that's a bluish discoloration on the flanks, or Cullen sign, which is a bluish discoloration around the umbilicus. These indicate seepage of blood-stained exudate from the inflamed, possibly hemorrhagic pancreas into the surrounding tissues. They are ominous signs.
Definitely signs of severe disease. What about other complications?
Complications can be local or systemic. Locally, we see pseudocysts. These are encapsulated collections of fluid near the pancreas. They can cause pain, a palpable mass, nausea, vomiting, and persistently high amylase levels. Then there are abscesses, which are infected pseudocysts. These present with high fever, leukocytosis, and abdominal pain, and almost always require surgical or percutaneous drainage.
Okay, so local fluid collections or infections. What about systemic effects?
Systemically, patients are at risk for serious cardiovascular issues like shock, and particularly pulmonary complications like acute respiratory distress syndrome, ARDS, pleural effusion, and atelectasis. The inflammatory mediators can really affect the lungs. Also, a critical electrolyte imbalance to monitor for is hypocalcemia. Calcium binds to free fatty acids released during fat necrosis in the pancreas. Low calcium can cause tetany symptoms like jerking, irritability, muscle twitching, or numbness and tingling around lips and fingers. Fosdex and Trousseau signs might be positive.
So how do we confirm acute pancreatitis, and then what are the absolutely crucial nursing interventions to stabilize these patients?
The primary diagnostic tests are elevated serum amylase and lipase levels. Lipase is often considered more specific to the pancreas, as other conditions can also raise amylase. You'll also potentially see increased liver enzymes if a gallstone is involved, high triglycerides, high glucose because pancreatic islet cells might be affected, and, as we mentioned, decreased calcium. A CT scan is generally the best imaging for diagnosis, and especially to identify complications like pseudocysts or necrosis.
Okay, so labs and imaging confirm it. What are the care goals?
The overarching goals of interprofessional care are aggressive pain relief, managing shock and preventing cardiovascular collapse, reducing pancreatic secretions to let it rest, correcting fluid and electrolyte imbalances, and preventing or treating infection.
Okay, let's talk nursing care. I know one of the first things you'll often hear is NPO. Can you explain why that's so foundational?
That's right. Keeping the patient NPO, nothing by mouth, is absolutely critical. Any food or fluid intake stimulates the pancreas to release more enzymes, which worsens the autodigestion and inflammation. We need to allow the pancreas to rest and heal. If nausea and vomiting are severe, an NG tube with suction may be used to decompress the stomach and further reduce stimulation
Makes sense.
and the pain. Intravenous opioid analgesics are essential. Morphine or hydromorphone are commonly used. Remember, this pain is often excruciating and requires aggressive management. Patient comfort is a priority. We also use aggressive IV hydration with solutions like lactated ringers or normal saline to correct fluid and electrolyte imbalances, replace fluid lost into the retroperitoneum, third spacing, and prevent hypovolemic shock. You have to closely monitor vital signs, urine output, and overall fluid balance intake and output are critical.
Okay, NPO, pain meds, fluids. What else is key?
Given the significant risk of respiratory complications, regularly assess respiratory function check rate, depth, effort, listen to lung sounds, monitor O2 saturation. Positioning patients in semi-Fowlers helps lung expansion. Encouraging coughing and deep breathing, using incentive spirometry, and frequent turning are crucial to help prevent atelectasis and pneumonia.
Respiratory care is huge. And the calcium.
Yes, since hypocalcemia can lead to tetany, continuously monitor for signs like jerking, tingling, or muscle spasms. Check for positive Chvostek's or Trousseau signs. Be prepared to administer calcium gluconate intravenously if ordered, and monitor the patient closely during infusion. It's also vital to observe for fever and other signs of infection, as infected pancreatic necrosis is a leading cause of mortality in severe pancreatitis. Antibiotics will be given if infection is suspected or confirmed.
Okay. And when can they finally eat again?
When oral intake does resume, usually once pain is controlled and amylase lipase levels are decreasing, you start slowly. Usually clear liquids first, then advancing to small, frequent, high-carbohydrate meals. It's crucial to strictly avoid high-fat foods, as fat is the strongest stimulant for pancreatic enzyme secretion. Patient education here is vital, reinforcing alcohol cessation, absolutely no alcohol, and avoiding smoking, as it's also linked to pancreatitis. They also need to know the symptoms of recurrence. 4. The gallbladder, cholelithiasis, and cholecystitis bile flow issues. All right, finally, let's turn our attention to the gallbladder and the very common problems of gallstones or cholelithiasis and gallbladder inflammation, cholecystitis. These two conditions are very frequently linked, almost like cause and effect in many cases.
Okay, the gallbladder. What causes these stones to form in the first place? And who's typically most at risk for developing them? The classic Fs, maybe.
Yes, the mnemonic about female, fat, 40, fertile still holds some truth, though it's a bit simplistic. Gallstones develop when the delicate balance of cholesterol, bile salts, and calcium in bile is altered. Bile basically becomes supersaturated with one of these components, causing substances to precipitate and solidify into stones. Most common are mixed cholesterol stones. Conditions like supersaturation of bile with cholesterol, decreased bile acids needed to keep cholesterol dissolved, and bile stasis, which is simply slowed or incomplete gallbladder emptying, all contribute.
So things that upset that balance, who gets it most often?
Risk factors are significant. Gallstones are far more common in women, especially multiparous women, those who've had multiple pregnancies, and women over 40. Estrogen, both from pregnancy and hormone replacement therapy or oral contraceptives, seems to play a role by increasing cholesterol secretion in bile. Other big risk factors include obesity, a sedentary lifestyle, rapid weight loss, and a family history or familial tendency. And cholecystitis, the inflammation of the gallbladder, is most often directly caused by a gallstone obstructing the cystic duct, the tube draining the gallbladder. Bile gets trapped, causing pressure, inflammation, and sometimes infection.
Okay, makes sense. So how does this actually present in a patient? What are the classic symptoms that would lead you to suspect a gallbladder problem?
Gallstones can actually be completely asymptomatic silent stones. Many people have them and don't know it, but when they cause symptoms, it's often dramatic and unforgettable. The classic sign is biliary colic. This is excruciating pain, usually in the right upper quadrant RUQ, sometimes radiating to the right shoulder and scapula. That referred pain is due to shared nerve pathways.
And when does this pain typically hit?
A key assessment point. This pain often occurs 3 to 6 hours after eating a high-fat meal, which stimulates gallbladder contraction against the obstructing stone, or sometimes just when the patient lies down. If a total obstruction of the common bile duct occurs, you'll also see jaundice, dark amber to brown urine, and clay-colored stools because bile can't reach the intestine. You might also see pruritus from bile salt accumulation under the skin, and fat intolerance bloating, nausea after fatty foods due to the lack of bile for digestion.
Okay, so pain after fatty meals, maybe jaundice. What about acute inflammation, cholecystitis?
Acute cholecystitis typically presents with indigestion, persistent RUQ pain and tenderness often localized at Murphy's point fever, chills, nausea, and vomiting. The gallbladder wall itself is inflamed.
And potential complications if things get worse.
Complications can be severe. They include gangrenous cholecystitis, where the tissue dies, pancreatitis if the stone blocks the pancreatic duct as well, cholangitis, which is inflammation of the biliary ducts, and even rupture of the gallbladder, leading to bile peritonitis, a surgical emergency. Choledocholithesis, which is simply a stone lodged in the common bile duct, is another serious complication that requires intervention to prevent cholangitis or pancreatitis.
How do we diagnose and manage these gallbladder issues, from conservative treatments to often surgery?
Ultrasound is almost always the primary diagnostic tool for gallstones. It's quick, non-invasive, highly accurate, and readily available. An ERCP, or endoscopic retrograde cholangiopancreatography, is more invasive but can visualize the bile and pancreatic ducts directly. Crucially, during an ERCP, stones can often be removed from the common bile duct or stents placed.
So ERCP is diagnostic and therapeutic. What about managing an acute attack?
Conservative therapy for an acute episode of cholecystitis focuses on aggressive pain control, usually with opioids, antibiotics if infection is suspected, maintaining fluid and electrolyte balance with IV fluids, and sometimes an NG tube for severe nausea or vomiting to rest the bowel and decompress the stomach. In some select cases, oral bile acids like ursodiol can sometimes dissolve smaller cholesterol stones over time, and ESWL, extracorporeal shockwave lithotripsy, uses shockwaves to break up stones, but these are less common now.
So what's the main treatment usually?
For symptomatic gallstones, laparoscopic cholecystectomy surgical removal of the gallbladder is the definitive treatment of choice. It's done through several small abdominal punctures. It's a remarkably safe procedure with minimal postoperative pain compared to open surgery, and usually a quick recovery, often same day or overnight stay.
That sounds much better than older methods. What's a key post-op nursing intervention after lap col?
A key post-op nursing intervention specific to laparoscopic surgery is to help manage referred shoulder pain. This is common and caused by CO2 gas used to inflate the abdomen during surgery, irritating the phrenic nerve and diaphragm. Positioning the patient on their left side with the right knee flexed, using a heating pad sometimes, and encouraging early ambulation helps dissipate the gas and relieve the pain.
Good tip. What if they needed open surgery?
For an incisional open cholecystectomy, which is less common now but used for complex cases, or if laparoscopic isn't feasible, a larger incision is made. In these cases, a T-tube may be placed in the common bile duct. This tube maintains patency of the duct and allows excess bile to drain externally while postoperative swelling subsides. Nursing care involves meticulously monitoring the T-tube drainage amount, color, consistency, ensuring the tube is patent, protecting the skin around the site from bile irritation, it's very caustic, and clamping the tube per protocol before removal to assess tolerance.
Okay, careful T-tube management. And what about dietary teaching for our patients, post-surgery or for managing symptoms?
Initially, for symptomatic patients or during acute episodes before surgery, a low-fat diet, small frequent meals, and avoiding rapid weight loss are generally recommended. Post-laparoscopic cholecystectomy, most patients quickly resume normal activities and a regular diet within a few days. The body adapts to bile dripping directly into the intestine, though some may find a low-fat diet helpful for a few weeks as their digestive system adjusts. For an incisional surgery, fat restriction might be needed for a longer period, perhaps 4 to 6 weeks. It's crucial to educate all patients on signs of complications like obstruction, jaundice, clay-colored stools, infection, fever, redness at incision, potential bleeding tendencies if liver function was also affected, and the importance of continued follow-up. Outro.
Wow, that was a truly immersive deep dive into the complex world of the liver, pancreas, and gallbladder. We've covered everything from those silent viral invaders like hepatitis C to the agonizing pain of acute pancreatitis and the very common issue of gallstones. It's so clear these organs are a tightly integrated team, isn't it? And understanding their individual dysfunctions really helps you see the bigger picture of your patient's health, just as your Lewis Medical Surgical text emphasizes.
Indeed. The interconnectedness means a problem in one area can quickly cascade throughout the system. It really underscores the need for holistic assessment. As nurses, your critical assessment skills, your ability to identify subtle changes and manifestations that slate change in mental status, the onset of RUQ pain, and your understanding of priority interventions are absolutely paramount. From managing ascites and cirrhosis to ensuring pancreatic rest in acute pancreatitis and guiding patients through post-cholecystectomy recovery, your role is absolutely vital for positive patient outcomes and, of course, for your NCLEX success.
So what does this all mean for you as you continue your journey in nursing? It means seeing these conditions not just as textbook entries, right, but as real-world scenarios where your knowledge and compassionate care make all the difference. Think about how crucial patient education on things like diet, alcohol cessation, medication adherence is for the trajectory of these often chronic conditions. How will you empower your patients to take control of their health and actively participate in their healing?
That's a great question. Something to mull over as you continue developing your practice and critical thinking. Thank you for joining us on this deep dive. Stay curious, keep learning, and go make a difference.
We truly appreciate you tuning in. Until next time.